Coming from the first national APAPP Conference. My name is Vinny Dorenzo. I'm a physician assistant in the medical ICU at the University of Rochester Medical Center, Strong Memorial Hospital. Here with a few colleagues to talk about the lifespan of COPD. So without further ado, let them introduce themselves.
Hi, my name's Laura Lonadier. I'm actually a nurse practitioner that works in the big state of Mississippi. I work for a private practice that serves as more of a consultative for pulmonary as well as critical care and the intensivist for several hospitals in the city where we actually care for all kind of patients that has pulmonary disease.
And my name is Barb Chamness, nurse practitioner. I work in a private practice in Colorado Springs, working primarily in the outpatient setting, managing all aspects of outpatient pulmonary and sleep. So I'm going to get this topic started with discussing outpatient diagnosis, management of patients with COPD. And so the biggest issue, I think, with COPD is getting an accurate diagnosis. A lot of times, we get a patient who was referred for COPD just because they smoke. And now we know that smoking is not the only risk factor for COPD. There's other risk factors for developing COPD. And not everybody that smokes will develop COPD. So making sure to look at, the appropriate diagnosis. So going with the GOLD guidelines is that a person that has on spirometry an FEV1 FVC ratio of less than 70 is a diagnosis for COPD. One of the new things that is emerging in diagnosing a COPD is pre-COPD. So a patient that has symptoms of COPD, they might have some structural changes of COPD on their imaging, but they don't have any obstruction on their spirometry. Or there's another category of PRISM, so preserved spirometry, where the ratio is 70 or greater, but they might have a decrease in their FVC or FEV1 along with symptoms and maybe along with some other structural changes on their imaging. And so these are kind of some things that we have to look at whenever we're looking at diagnosing, not just the spirometry, but also radiographic testing and any other testing that you're going to consider to rule out any other differential diagnosis. And so there's a lot of comorbidities with COPD in the age population. We have to look at other heart considerations and other infectious type of things that might be considered in ruling out diagnosis of COPD as well.
Gotcha. So, Barb, I'm just a resuscitation jockey. So help me out. When I have the patient that comes into the hospital and they have the COPD diagnosis on their problem list, and there's never been a PFT done, but they're on inhalers, they're on ICS. Do you ever get those patients referred to you? How do you approach a patient that has the clinical COPD diagnosis without the PFTs?
Yes, so the biggest symptom that we look at is dyspnea, but we know that COPD is not the only condition that can cause dyspnea. Other symptoms with sputum production, wheezing, cough, and mucus, we have to look at those as well. But sometimes we can find another test, like a CT scan of the chest, that might show some emphysema or a chest X-ray that looks hyperinflated, that we can maybe get a kind of more of a clinical diagnosis without a pulmonary function test. Again, that comes in with the pre-COPD, where even if they have, all the symptoms, they can have a normal spirometry. And then the other portion of it is, are they responding appropriately to the treatment? So if you've never tried them on an inhaler, or they have the dyspnea but they never have relief from the inhaler, we have to consider, is this truly COPD or a COPD exacerbation in an inpatient setting, or is this something else going on? And so that's kind of one of the challenges, I think, whenever we have a patient with that age group, 40 to 90 or 100 with dyspnea. Is it truly COPD just because they have a smoking history, or is there something else going on? And so a lot of other comorbidities involved with patients that have COPD are heart disease, metabolic syndrome, sleep apnea, bronchiectasis, all sorts of other things can be associated with COPD as well, that kind of looking at the whole picture. And then there are other considerations for COPD that we don't think about very often, more so maybe with people that were asthmatic as a child. There's the new taxonomy coming, being looked into for patients that have history of previous pneumonias that now develop COPD, or biomass fuel exposure that have COPD, patients that have lived in, LA in the 70s with the pollution. We have to look at other things, not just smoking history. I was like, oh, you never smoked, you don't have COPD, which is not always the case either. So taking a good history, that's one of the beginning points of, diagnosing COPD appropriately. A good physical assessment. I've had patients come in with dyspnea for a COPD referral and their heart rate is 25. And I think, maybe you don't have COPD. Maybe you need to go to the ER, or they're having, palpitations or other arrhythmias or that kind of thing. And we diagnose other cardiac problems in place of COPD. Whether there's, overlap, that wasn't the primary cause of their dyspnea on assessment. And so the GOLD guidelines recommend, like I said, the FEV1 FVC ratio of less than 7. Then the ATS also has a guideline where they have the lower limit of normal on the ratio. And so that incorporates age-related functional decline in the pulmonary function test, which the GOLD doesn't take into account. However, there are some studies that show that where someone might not be diagnosed with COPD because of their age and their ratio is greater than the lower limit of normal, they still have symptoms of COPD. They still have structural changes on their imaging. And so some suggest that maybe, using the set ratios might be a better diagnosis rather than using, the lower limit of normal. I think, again, we have to look at the whole picture as far as symptoms, response to treatment, and the spirometry as well. So once we've gotten an accurate diagnosis of COPD, we have to determine what kind of treatments we're going to utilize. The biggest thing with COPD treatment is to improve quality of life, to prevent disease progression, and to prevent exacerbation, because we know that COPD is a chronic condition that can be prone to good days, bad days, can be prone to flare-ups and exacerbations, which could lead to hospitalization. And so ultimately the goal would be to prevent those things, to preserve lung function and improve quality of life overall. There's a lot of non-pharmacological treatments, including lifestyle modifications, pulmonary rehab, oxygen, supplementation, making sure preventative therapies are in place, such as vaccines, smoking cessation, avoiding triggers, that kind of thing. In more severe cases, we're going to look at interventional pulmonology, such as endobronchial valve, other lung reduction surgeries. Cryo is starting to come out now, and other interventional pulmonology procedures to help improve symptoms and quality of life and decrease dyspnea. The other things we take into consideration are the severity of their symptoms. So using scales like the MMRC and the CAT to determine their severity of their symptoms, because the grade of their symptoms, so GOLD 1, 2, 3, which would be mild, moderate, severe, very severe. ATS has mild, moderate, moderately severe, severe, and very severe, doesn't necessarily align with their symptoms. And so a lot of times we have to look at their symptoms. And the dyspnea scale is great. It shows, are they short of breath? Are they not so short of breath? But there's another whole laundry list of symptoms that patients are having that doesn't fall into that category. And so the CAT has 8, I believe it's 8 other symptoms that they look at. And so using both of those is a really good tool to determine where are we going to start on the treatment when we're talking about pharmacological bronchodilation. And the GOLD guidelines has the GOLD ABE assessment, which recommends the therapy to start with depending on the category. So a patient that has not very many symptoms and they're not prone to exacerbation, we're going to start with a bronchodilator, maybe a single bronchodilator. A patient that has maybe a little bit more symptoms, still not prone to exacerbation, we start with a dual therapy, long-acting bronchodilators, the LAMA-LABA. And then the category E is the patients that are very symptomatic and they're having exacerbations, 1 hospitalization or 2 a year. We want to start those patients on a LAMA-LABA and or consider inhaled corticosteroids for those that are have more inflammatory features.
So, Barb, if I can back up for a second to the spirometry. At ATS and CHEST this past year, there was a lot of talk about racially blinded or racially adjusted spirometry. And as someone who's making the diagnosis of COPD, what has your experience with that been?
My experience personally is we have adjusted our pulmonary function testing to eliminate those kind of racial changes. I think Gold has come out with their set ranges for age and sex. And so I haven't had a lot of experience as far as looking into data on the differences between race and spirometry, just kind of going with the updated programs for our pulmonary function testing as a new way to assess those. I think when we're looking at pulmonary function testing, the anatomy of the person is probably going to play more role than their race. Someone that's 6 feet tall has a longer set of lungs than someone that's 5'2". Those are things I think are more important than race. But I think I need more education on that. So if you know any more on that.
Woefully ignorant. I've got one of our faculty at my institution has worked and published a few things this past year, and there's a lot of work being done out of Columbia, I know, looking at those kind of things and trying to work those recommendations and to get rid of that racial adjustment to not have health inequities that are so often. And, it came out 18 months ago, 24 months ago, I think at this point, that our SpO2 monitors in the hospital have bias against folks with higher amounts of melanin. So I think there's just a lot of things that have come to light, and it's an evolving thing, and I think it's driven by folks trying to do better for our patients. So it's nice to see. And again, as somebody who's not making the diagnosis, I appreciate your candid.
I think there has been a disparity in this topic for a long time, just with the limited number of participants in studies and how, like you said, the pulse oximetries have been tested previously. And so I think we just need more studies and more data to really fully understand a little bit better. And unfortunately, that does cause some problems with patients having more issues with exacerbations or decreased symptoms or on oxygen or not on oxygen because of their race. And so I think looking at the patient as a whole, really getting, like I said, a good history and using those other screening tools is going to drive it more so than the spirometry. Because if you have a patient that has very severe COPD, very severe emphysema, their only symptom is shortness of breath and low oxygen, they may not have a lot of significant change with or without a bronchodilator. And so that's coming into looking at the whole picture and not just following a guideline and saying you need triple therapy because you have a very severe obstruction on your spirometry. And so tailoring that treatment to the individual is an important part of that aspect. And then when choosing an inhaler also, it's important to look at that patient's ability to be compliant with that inhaler, to be able to use the device properly, and really getting a good assessment on their physical capabilities, their inspiratory effort. If they have rheumatoid arthritis, are they going to be able to use the Respimat type of inhalers? All of these things we have to take into consideration. And then the biggest thing with treating COPD is follow-up, so we don't just prescribe the medication and then send them on their way. We have to have a good follow-up and making sure that, are you feeling better, using those MMRC and CAT scales prior to and after the fact so they can see also that, previously you scored here and now you're showing improvement in your symptoms. And so that we're not just having them out there still having significant amount of symptoms or impaired quality of life. And so the follow-up is important. Also, monitoring exacerbations. And so we want to have the best optimal treatment outpatient to prevent, hopefully, exacerbations. And we all know that exacerbations can happen for no known reason. They can be very well controlled, and for no reason they can have an exacerbation. And so an exacerbation, I tell my patients, is any increased cough, wheezing, chest tightness, shortness of breath, change in mucus that's not your normal or not your baseline. And I think the key for treating exacerbation is catching it soon, catching it before they get into a situation where they can't breathe and then they have to go to the hospital. and determining what kind of therapy they need. So the GOLD guidelines do talk about mild, moderate, and severe exacerbation. So if someone's just a little bit tight, more than normal, you might be able to get away with just doing a bronchodilator, one day, and then the next day they're fine, or, might add a little bit of oral corticosteroid. And then depending on, the severity of the exacerbation will depend on the treatment. Outpatient, we see a lot of mild to moderate exacerbations to where they might need a little bit of extra bronchodilation. We might add in an additional inhaled corticosteroid or oral steroid, or an antibiotic, depending. Majority of the time, the antibiotic is added in for patients that have change in their sputum consistency or frequency. Sometimes we'll do it for, if they're hypoxemic more so, or tachycardic more so, to prevent pneumonia and to hopefully prevent them from having to go into the hospital. And so, but the best key for exacerbation is prevention. And so that's going to be starting with good outpatient management and education to the patient. And so I manage outpatient. If they fail therapy, this is just my practice. If they fail 2 rounds of outpatient therapy, then, they need to go to the hospital. Or if they have a situation where they're very severely, in that category, and I'll let Laura talk about the severity of COPD exacerbation, what institutes needing to be inpatient or hospitalized, then that's usually where I'll refer them.
I have 2 questions to follow up on your topics. One of them is, we talked about PFTs and the symptoms that they express. Well, you live in Colorado, yes. So does that take into account? Because I don't have any pulmonary issues, but when I went to Colorado, I was short of breath. So
yes, definitely shortness of breath and the threshold for hypoxemia are different at higher elevation, and so we definitely have to take that into consideration. We're a little bit more permissive with outpatient hypoxemia, I think, than you would be at sea level. The ranges are different. So 90% SpO2 at sea level, people start getting a little bit nervous. We don't start getting too nervous until their SpO2 is 88% or less. And then, if they have, a lot of them already have supplemental oxygen just because of that factor. But if someone, at their baseline can be on room air and maybe only need oxygen at night or with activity, is now saturating in the 80s, at rest, that's something that we have to take into consider. Do they need to go to the hospital for that? And, sometimes with patients that are very severe in their COPD, they don't want to go to the hospital. And so we try to do our best to compromise and keep the patient safe. Sometimes we'll have people come in every day to get, injection of steroid and just check in every day. But ultimately, the patient's always instructed, go to the emergency department if you have XYZ. And so
I guess the second question kind of goes along with that. When you were saying that you try to treat them twice outpatient and then instruct them they need the hospital for further evaluation. So does your patients, do they receive some form of flyer or handout, I guess is a better word, or something that says if you have these many episodes, or if you are unable to, walk from your living room to your den, those kind of things, is there something that triggers other than just you have an increase in your symptoms, or is that? And because I guess my question is, do they understand, the increase? From Mississippi, we may not be quite up on the concept of that. So
I think it's definitely, I don't have a handout. We do have cards in our office that talk about what a COPD exacerbation is and what kind of symptoms to look for. And each patient is a little bit different. We have to look at, like I said, the whole patient, the whole picture. But, standard, typical is someone comes in with exacerbation symptoms. We give them the course of the oral steroid and or antibiotic, have them return to the clinic in a set period of time. If they're still having symptoms, if they're worse, they go to the hospital. If they're same, we might extend that course. So that would be the second round. And if they're not better by then, we have to determine, is there something else? Do they need more than the outpatient setting can provide them for support at that point? I hope that answered your question.
We did.
Yeah. Okay.
All right. So we'll talk about those patients who have failed outpatient or those who are being hospitalized. It can even be for those that's an acute onset. As you said, there's different causes for an exacerbation. It's a worsening or flare up of their symptoms, whether it be the dyspnea, the shortness of breath, or the sputum production, or they're complaining about their wheezing and can't walk from one room to another, or if they can't go to their mailbox. And the causes can be different things. Infection is one, viral can be, of course, and then the irritating substances. We see a lot of patients who, like candles, may make them flare. Pollen, that pollen time of the year, the perfumes. I don't know about y'all, but in my training, that was one of the biggest things in nursing. You couldn't wear perfumes because it caused a patient to have exacerbations. And then, of course, a lot of times we even have seen some, like during the winter months when they start using those fireplaces, that smoke would cause them. And of course, sometimes we, like you said, we never know what causes them to have an exacerbation. And of course, the biggest hallmarks that we see for exacerbation is usually it occurs within hours to days. It's usually within the 2 weeks you start seeing more symptoms, and most of them do complain of the same things. They get more short of breath or dyspneic. They have a new or an increase in cough, because some people have a continuous chronic cough. And then, of course, they start talking about how much sputum they're actually producing, or it's had a big color change, and that always concerns them. Put on my glasses, y'all. And there are the different stages, the mild, the moderate, and the severe. And that all has to deal with their dyspnea. It also has to do with their respiratory rate, their heart rate, and then, of course, their SATs. For those patients who get more severe, we become more comfortable with 88% or above. For those patients more severe, a lot of them are on home oxygen. And you'll notice that they'll start telling you when you're doing your assessment, when they're admitted, about, well, they're usually on 2 liters and now they're on 5 and they're still short of breath, or the home SAT. A lot of the patients who are treated for moderate and severe COPD have their home SATs. Of course, COVID, a lot of people went out and started getting SATs because they were watching their saturations. So you have to, those are one of the things we see. But once they're hospitalized or deemed to be hospitalized, by the gold standards itself, it has to be they have more severe symptoms with the dyspnea, the worsening of the respiratory just at rest, and then, of course, a decrease in their oxygen sats. Someone will become more confused and drowsy and have an altered mental status because their oxygen level have declined so much that it's changing their mentation. They usually have maybe some new symptoms, cyanosis that they didn't have before, of course, some peripheral edema. They usually have failed outpatient unless these are people that have had the acute onset. They were fine this morning, now they're not. And there may be some other comorbidities that implement their need to be hospitalized. Now they're in atrial fib that they didn't have before. COPD and heart failure sometimes are very difficult to determine which is the main flare. And then, of course, sometimes we have admitted patients because they have nobody at home. We have some of these chronic patients who live alone. Now, when they're presenting, you just had to decide, is it going to be, do they get to go to a private room or do they need to go to intensive care? And to determine if they're ICU, it's going to be if they don't respond to the initial therapy that we have prescribed to them in the emergency room by the emergency room provider or whoever the admitting provider is, and they're continuing having a mental status change or encephalopathy. Their oxygen status has not responded to the initial by either, if they're on home oxygen, a lot of times we'll start face mask. If the emergency system has brought them in, they usually put them on, face mask. Some of them have put them on BiPAP therapy or PAP therapy. And if they're still not responding, and they have to progress, of course, to a mechanical ventilation ICU. And then if they're just unstable, we do have a lot of patients who become hemodynamically unstable, where their blood pressure now is in the 70s or 60s, or they're so tachycardic. So, and of course, initially, whether they're inpatient or to the med-surg floor, or whether they're admitted to the ICU, our management essentially starts the same way. We start giving them some inhaled beta-2 agonists and some anticholinergics. We start giving the IV normally if they're wheezing or they're severe, they corticosteroids, mostly to help improve their lung function and oxygenation. And then, of course, antibiotics. If there's any infiltrates, some people will lean toward the pneumonia pathway of having Rocephin and Zithromax. Doxycycline is a very common medication we use. Of course, Levaquin, every once in a while you'll still use, but some people are trying to stay away from that because of the resistance we have found with those. So initially, if they don't respond to oxygenation and they're not severely hypoxic or their mentation, we do try the non-invasive mechanical ventilation for those patients. And it's just to see if we can support that acute respiratory failure they have. And it does show that it increases their gas exchange. It does reduce their work of breathing and hopefully decrease their risk of trying or need to be intubated. It can decrease their hospital stay and then, of course, improves their survival. And a lot of those patients we see because of the work of breathing, or they have a respiratory acidosis. And, of course, they're persistently hypoxic despite oxygen use. Now, some of them do progress to invasive, mechanical ventilation or intubation. And some of those patients, depending on the work that we have seen in the clinic setting, some patients will come in and have already decided they do not want to be intubated, or, they already know that their disease is end stage, or it's something they've seen their family before go through and they don't want to do that. But for those who are willing to go through at least a trial, then we will do an intubation on them, and especially if they have failed the non-invasive. If they've had some kind of arrest, if they're persistently having altered mental status, if they're at risk of aspiration or vomiting, they don't need to be on a PAP therapy. That, or you're just going to push, that the PAP therapy is just going to cause them to have a true aspiration. And then, of course, if they're having trouble removing their secretions, they're hemodynamically unstable, start having any kind of life-threatening arrhythmias, and then, of course, if they are severely hypoxic, they're not responding. So once they have become a patient that's on the vent, then we have different paths. For somebody that's got COPD, it's very difficult to determine how quickly, and that's one of the questions I get. I don't know about Benny if you do, but how long are they going to have to be on the vent?
All the time.
And you can't tell them, and we tell them that every individual's different. The goal is to get them off as quickly as possible. So we try weaning every day. And that's the standard. You have to look at their extubation criteria. Do they meet the extubation criteria? We have them on sedation, and sedation is to help the patient get maximum benefits from being on the ventilator. But if you start weaning their sedation and they become tachycardic, hypertensive, they get tachycardic as well as the tachypnic, then the difficulty is you can't wean them when they're fighting the vent.
Is this the criteria that you're referring to, or what? I don't work in inpatient, and I've never worked in the intensive care with mechanically ventilated patients. And so what is the criteria to determine if you're going to try to wean that day versus not? Or is it they're going to be weaned trial every day regardless?
No, usually we look at their oxygen percentage and their vital signs, of course. And then we have to know that most individuals want their FO2, their oxygen level, 50% or less on the vent. Their PEEP, most people want it 7 or less. Some of us old school still like it around 5, but the newer guidelines and standards are saying 7. And then, of course, you have to start weaning them. They do a spontaneous assessment to look and see first if they can come off do the ABGs meet the criteria. That means they have to be compensated. The pH has to be normally within the normal range of 7.35 to 7.45. And then, of course, their oxygenation, you can't be 60 and you on a PEEP of 8 and a 60% FO2. Those are just not screened at all. They fail immediately. Then, of course, once you're able to decrease their sedation, and depends on what they're using. A lot of people use different things. Fentanyl, Versed, Propofol, Precedex are the main common ones we see around my area. Propofol because it does actually reverses quickly. Versed, you had to be careful for those heart failure and those, the end-stage renal patients because it does tend to hang on a little bit. Fentanyl is a good one. Of course, with the push today of, drugs being a concern, families are even concerned when you have them on pain medicine because then they're thinking you're going to get them addicted, and that's not the case. But you can actually screen them on a little bit of fentanyl. We try to get everything off. Precedex if they need it, and Precedex is just something we can use even on non-ventilated patients. We use it a lot on our PAP therapies, patients that's on the BiPAP, because it just relaxes them. Because when you got, there are thousands of people that wear a BiPAP every night, but it's a little different when it's forcing air into you at a different percentage and volume that they don't get if they're on a home CPAP.
And you're in acute respiratory failure situation.
Yeah.
Can't breathe at all.
Different.
So we look at their criteria first and then see if we can actually wean them, and then go from, if they can wean, the new guidelines, we try to get them, if they can tolerate a weaning and they're on what we call pressure support, or some people call it CPAP, but they're doing a spontaneous breathing trial. Then if they tolerate it, hopefully within 2 hours you can extubate them. But they still have to maintain their oxygen, their heart rate, their blood pressure. If they don't, and a lot of our COPDers do not get extubated that quickly. Some of them, we try to warn the families they may be on the vent, especially if they're end stage and we know they're end stage. We even tell them they may be on the vent a week, even up to 2 weeks. And usually if they are getting that progressive, then we got to start thinking of other things. We start thinking about nutrition. And then for some people that are severely hypoxic, then we have to start thinking about how can we support their hypoxia. We can't even try to wean them because of their hypoxia. And then you'll start seeing nitric oxide, Velitri come out to those. And you can actually attach those to non-invasive, but it's the ventilator patients that's on high PEEP. When you're getting people over 10, 12 PEEP pressure, you've got a concern with hypoxia. And we see that a lot. And then usually by the 2-week period, unless you've got a really aggressive management of provider, then PEGs and trachs are starting to be thinking about. And then you have to start thinking about other things. Do we need an LTAC to help try to wean them? Because this is going to be a very slow wean. Some of our severe end-stage patients, it's a slow wean. You're not talking about weaning them over, a couple of days like normal vents. You're talking about 2 weeks, a month, even longer on some of them. So, and then of course we try to get palliative care involved. Out of the 2 big hospitals we work at, we have one that's had very aggressive palliative care, and then we have one that I think they have palliative care, but you don't never see them. So we are the palliative care. And it's something important we try to tell the families, and we talk early when we're before we even intubate them, unless it's emergency. And if they're listed as a full code, we full force go ahead. But we try to talk to them about, is this something your loved one would need, or this was something your loved one would want before, because if they don't able to come off the vent, then we would have to progress to trach and peg. Some families will want to try whatever they can and give it an option or chance. And sometimes the families or the patient, if they've already got a healthcare administration or they have some form of documentation about what they want or don't want, we actually try to honor that as much as possible. But the families will overrule, even they want to give them at least a shot. So we'll try, but then they'll say if they're not able to come off in 2 weeks, we want to just remove it. And we do a palliative extubation. So there are other options that people can do, and I'm going to let Vinny talk about the more aggressive. Where I live, we don't do some of the aggressive. We don't have some of the things that they have. And also,
I did have one question. Mm-hmm. This is not going to probably be based on any numbers or data or studies, but when a patient that is in the hospital for a COPD exacerbation needing mechanical ventilation, how often is it purely COPD exacerbation, or do those patients tend to have an overlap of pneumonia or infection or something else going on?
I don't know percentage-wise, but there's a lot. A lot of times if they have infiltrates, you're going to treat them like they have pneumonia or COPD. And then we have some that have asthma and COPD, and they come in with it looks like a severe asthma. And then as it progresses, the wheezing's not there, so then you think maybe it's more COPD. COVID, of course, has been a combination of things. The flu is always an issue that adds a component to our COPD patients. But intubation, unfortunately, even with the area we live in, we have a lot of inhalants like vaping. We have a lot of patients had to be intubated because of their recreational drug use, because they have respiratory failure. So we have a lot of intubations that's not always COPD. Some of them you suspect they're COPD because, like Vinny was saying, some of the things you see with the COPDers, we have. I like to know what their echocardiogram is, especially if they have bilateral infiltrates, just to make sure and rule out. If we haven't had an echo ever, I tend to order echoes. I may not own a 20-year-old, but of course we're in the South, so it's not uncommon for a 20, 30, 40-year-old to have an EF 10 to 15%. But they have to have more symptoms. I say peripheral edema or something like that, that I will order it on a young one. But I do like to, if they're in their, getting up in their 40s, 50s and above, I do like to have a baseline echo. But it's all kind of things we may see, not just COPD, but there is a lot of times there is a combination, and they're treating them for both. Most of them are treated.
I'm thinking of like a COPD exacerbation with hypercapnic respiratory failure. Do you find that those patients respond well to non-invasive ventilation without any evidence of infiltrate, or do you find that there are patients, a high number, that still need mechanical intervention?
Yeah, so it's tough. I think we see a lot of the overlap. When I think of the folks that are coming in strictly with just an acute exacerbation of their COPD, usually the indication to intubate them has more to do with mental status than it does their acid base. Because these folks have a good amount of reserve and they're used to seeing those higher levels of PCO2. So they're having a conversation with you with the BiPAP on, even though their pH is 7.2. And so it's really tough to say, this is somebody that I want to put a breathing tube in, knowing, one, how challenging it's going to be to just manage them on the ventilator, because these lungs are not normal lungs and they create a lot of challenges in the minute to minute. And it's honestly dangerous. We think of obstructive lung disease, and those are the patients that make me the most nervous when we put them on the breathing machines. I'm by the bedside. We're really keeping an eye out for that air trapping and trying to make sure that we're not going to put them in a hemodynamically compromised position. So there is a lot of clinical overlap with other indications to put the breathing tube in as well. So a question I have for you, Laura, when you were talking about everything, when you have BiPAP or the positive pressure on these patients, you're supporting their breathing, what are your clinical targets, and how long, at least in your shop, are you tolerating positive pressure non-invasively on the floors before they come to the ICU?
Ooh, the floor depends. I guess it depends on who the admitting provider. A lot of the hospitalists run most of the patients, or the admitting providers. Mm-hmm. And some of them will be a little bit more cautious. If they put them on BiPAP, they come to ICU. Mm-hmm. And I'm not saying that's wrong. I'm just saying that does fill your ICUs up sometimes quicker than they should be, because the patient would probably respond well to that BiPAP. I'm not sure about you. We use BiPAP and we use AVAPs. Yeah. So that depends on the individual patient. If you have someone that's awake, alert, and talking to you, BiPAP's fine. Mm-hmm. Those patients who may be a little acidotic and they're a little hypercapnic, AVAPs is what we'll go to, because they're, but you got to be careful with that. It's just because it gives them the tidal volume we want them. But it's usually after 24 hours, though, if they are not off the BiPAP, most of the doctors will transition them, unless they're just truly sitting there wide awake, despite what their pH is, despite what their PCO2, because you have a lot of people that their baseline is 70. So, I can't tell you the number of calls I get at night reporting ABGs, and they're 7.37. PCO2 is 70, and they have to call, they said, because it's, abnormal. Okay, thank you. Because I'm not going to do anything about, somebody that's compensated, because, especially if they're what we call our Mississippi healthy, when their BMI is over 30. So, it's expected that a lot of them will have almost like a obesity hypoventilation syndrome with their and they probably are supposed to wear BiPAP or non-invasive at home, and they don't like that machine. It don't make them look sexy. So,
yeah, I know. I always I've got a few chronic patients that their baseline PCO2 is greater than 100, which is what our cutoff is in the EMR. So I always have to ask for the slip to see if we're actually making ground up or not. I have two more questions for you, Laura, about the inpatient management. One, you mentioned IV glucocorticoids in these folks, trying to get that inflammation down. What kind of dosing do you use? And I have a follow-up question based on your answer.
Oh, heavens. It depends. Everybody, because if we start the therapy, it's usually 60 at least every 4 hours, or every 6 hours, or every 8 hours. And it depends on the history. If we know the patients and we know that we've had to use steroids before, or if we've already treated them outpatient and they've already been on the oral steroids and they failed it. Yeah. Sometimes you will see if another group is admitted. Sometimes we'll see the 125, and we usually decrease that immediately, just because now the new standards and all showing you don't need 125 every 6 hours or every 8 hours. And then of course we actually have tried now to make it where they have a cutoff of how many days they get the IVs, and they initially then transition to a titration of oral. So we have order sets that do that.
Gotcha. Okay. So then my next question is so in the overlap of patients that have an acute exacerbation of their COPD and pulmonary infection and pneumonia, the Cape Cod trial came out in the past 18 months with the kind of stress dose steroid, hydrocortisone, 200 milligrams a day. In your shop, are you guys using that when you have that suspicion for overlap of infection and COPD? Or are you sticking kind of with the classic 60Q6 of the COPD steroid?
Pretty much the classic. I don't know, and it may be just, again, because sometimes they've already been started on the regimen by another provider, and we just, we don't hear wheezing. They don't really look like they're that sick, so they started it, we just let it go. And then a day or two later, it's like, okay, change them to oral dosing. So we do try to get them off the steroids because of the risk associated with the numerous steroid usage during a year. They're trying to limit 2 years. They don't really want you to have steroids more than 2 times a year if possible. So
if only.
If only. Yeah, exactly. We're in the South, that don't happen. So.
So, Vinny, tell us about what happens when they continue to decompensate on the ventilator.
Yeah, absolutely. So I am fortunate enough to work at an institution that is an ECMO center. So that's extracorporeal membrane oxygenation. So ECMO is a hot topic across the country. It kind of falls in the same category as some of like the sepsis adsorbers, where there's a big selection bias where folks that to get enrolled in any of these studies to give us any kind of data to see if there's good outcomes have to be really sick. So it's really tough to get good outcome data, especially if you're looking at mortality and folks that would qualify for these more invasive measures. Now, in the few months that we've been working on the talk that we're covering today and that we're going to talk later on in the conference here, they've actually published some new studies, particularly about the ECHO, which is the extracorporeal CO2 removal, which is sweep-only ECMO, which is classically veno-venous ECMO will do oxygenation and CO2 removal. This ECHO just does the CO2 removal. So the big study that came out for that was in January of 2024 in the ATS Critical Care Journal. And that was the Vent-Avoid trial. And they enrolled patients in an acute exacerbation of their COPD, either on BiPAP or already mechanically ventilated. And their primary outcome was ventilator-free days after 5 days. So the idea is that with this circuit, you're able to pull off the CO2 faster than their chronically damaged lungs would be able to. Unfortunately, the Vent-Avoid trial went the same way of the ELSO trial, which was the big ECMO study in adults, in that there really wasn't a benefit in the primary outcome. Now, again, you're choosing patients that are sick enough to meet these requirements for this intervention. One of the big drawbacks, too, for the COPD population at least, is you have a lack of benefits. You've got a lot of risk associated with a big catheter that's going to require a multi-step dilation. There's going to be bleeding risk. There's infection risk. If you have patients that can't otherwise tolerate systemic anticoagulation, the risk of thrombus is really high as well. The idea with ECHO is that you could put somebody on this kind of big deal mechanical circulatory support, but keep them extubated and keep the BiPAP off or get them extubated much more quickly. Unfortunately, to date, hasn't really panned out in the literature. There's a few centers that are still doing it. And if you look up the ELSO guidelines, which are the ECMO guidelines, acute exacerbation of COPD falls in this gray area because it is a reversible process. So if you have somebody who's stuck on the ventilator and you can't get their pH up, you can't get their oxygenation better, they're horribly overdistended, they're starting to breath stack, you have the option to put them on these mechanical circulatory support systems. However, if their lungs are that bad, what's the bridge? Are we going to get these patients extubated? Are we going to get them to a transplant? And that's where they fall into this category of maybe not qualifying for mechanical circulatory support. So it's a really challenging approach. There's a lot of ethical debates about who should actually be getting these therapies and these interventions, because it's really tough to say who falls on that line, particularly with the COPD patient, of reversible cause and stage disease. And to pull those apart is really, really challenging. And as of right now, we don't quite have the data to support one or the other. There's some centers and there's some great anecdotal evidence, and there's been some physiologic studies that make it seem like maybe we should get there. And one of the drawbacks of that Event Avoid trial was actually stopped early, so they didn't meet their enrollment for their effect size. So while we have this signal of, it looks like there's no benefit and there's a little bit of harm, we don't have the data to say yes or no. So there's a few echo centers that are still around the country and around the world that are still doing this and still studying it. There's a few ongoing trials now. ECMO trials, again, very challenging to do because you've got folks that need to be sick enough to require that, and then folks that are willing to sign up for the study. So it's an evolving field, but when you're in a center that offers those services and you've got a patient who's really up against the wall, and Laura, as you know, sometimes those COPD patients on the ventilator get into really scary spots, and they're not at a point where you can trial an extubation or move them to a tracheostomy. It's really challenging. So then the end game of all of this is what happens with the patient who is at that end stage disease. What do we do with the patient who doesn't have treatment options left? And, we're learning about new medications and new interventions that we can do to try to prolong their life and to diminish their suffering while they're doing that. But at the end of the day, none of us are getting out of this life alive. And it's a reality that we all have to face sooner rather than later for some. So how do we have those conversations when we get there? Now, palliative care, I think for the layperson, is not well understood. I think it goes hand in hand with hospice for most people, and they don't realize that. And I think a lot of providers too, and this is talking across my large health system and my alumni network and all those kind of things, there's not a lot of understanding about palliative care and what services they can provide. And then the question comes up, even if you do know what they can offer your patients, when you get them involved, right? I think everyone kind of keys in on, all right, hospice is if you're going to die within the next 6 months, and other than that, we're not going to talk to them. And I think that's a timeline that a lot of people associate with palliative care. And the thing is, you can get palliative care involved at any point, outpatient or inpatient. And it's one of the things that, particularly on the inpatient side, we've got rotating schedules, we're shift workers. We may not have the continuity to have those challenging conversations with the patients. So to have a dedicated team that can follow them along the disease process can be especially helpful. From my pulmonary colleagues at my shop, same thing. If you've got a 15-minute clinic visit, it's really tough to have these conversations in 15 minutes. It's exceedingly tough to have it on the inpatient side of things when the patient can't participate. So some of the things that we can do is to get those palliative care folks involved earlier and to empower our patients to have those conversations, as tough as they are, with their loved ones. Find a healthcare proxy. As the old adage says, you got to find someone who can live without you to be your healthcare proxy, to make the decisions and honor the wishes you want for yourself, right? There's been a whole host of narrative reviews that have been done, and there's not great consensus on how do we approach palliative care in any disease state, let alone COPD, which is a disease that patients live with for a really long time. And I think a lot of the patients with COPD are quite resilient, and they're able to tolerate diminishing quality of life over time. Granted, they still have exacerbations, they still have things that need to be treated, but I've seen a lot of folks that in a 5-year span go from living independently to having oxygen around the clock to being BiPAP dependent at night. And they take all that in stride. And I think it speaks to their spirit and the fact that it's really viewed, as it should be, as a chronic disease. But at the end of the day, there is an endpoint if something doesn't get you first. There's a review by Iyer et al. That puts out these 8 domains of palliative care and COPD. And it really comes from an approach that looks at everything that goes into the patient. And I think it's a movement that's been going on in healthcare for a while and is refined over the past couple of years. So those domains go through things like the structure and process of care. How do we coordinate the inpatient providers, the outpatient providers, the palliative care providers, the rest of their healthcare, right? Because your COPD is going to depend on how everything else is going as well. It looks at the physical aspects of care. How do we treat those symptoms? How do we get patients feeling good about where they're at? There's the psychological and psychiatric aspect of care too, right? Chronic illness has a lot of overlap with mental health and mental distress. Not only is it underdiagnosed, but it's undertreated, even if it is diagnosed. So it's acknowledging the challenges that these patients are going to have as they go through that process. The next few domains are a lot more holistic. They look at the social, spiritual, and cultural aspects of care, across the country, across socioeconomic groups, across cultural groups. How do you view death and dying? How do you view the end of life? How do you view the things that are important to you and your family? And then what supports do you have? Are you someone whose the system's let down a lot? Or are you someone that's got a big, strong support system that, you can't go to the grocery store anymore, but you've got 8 grandkids that are willing to run around and do your chores for you, right? That makes a big difference for folks. And then the last piece is really the end game to all of this, which is the medical, legal, and end-of-life care, is when we get to that point of, living in a skilled nursing facility with a trach and a peg was not something that we were interested in. How do we make that transition? And unfortunately, a lot of those folks usually end up intubated before we make that decision. Like you said, we give them a shot on the ventilator. We try to, whether it's within their wishes or not, based on what the healthcare proxy says to us, we give them a shot, and do we move towards that compassionate extubation and having those tough conversations? Obviously, that's happening a little bit more on the inpatient side, but having a plan ahead of time, designating those living wills, understanding what is a concrete thing and what is not a concrete thing, discussing code status. I think all of that, the earlier it's discussed, the better. And it's, like I said, it's tough to have the conversation with the family at the bedside when it's never been addressed before, and we've seen the train coming down the tracks for quite some time. Now, granted, there's acute things that come up, and it's not always a COPD that gets them, but it can be a complicating factor when they do need those life-saving interventions. So the person with the really bad pneumonia that has horrible septic shock, and then they go into renal failure. God bless Mississippi, you guys have LTACs. In New York State, it is really challenging. If you have a patient who's ventilator and dialysis dependent, they're going to live in the hospital. There's nowhere for them to go.
Well, Mississippi, they don't either.
Okay,
They have to go out of state if they have a trach and they're on end stage. They can only have one end of life disease. It can't be COPD and end stage.
Yeah. So we're kindred spirits in
Yeah.
that one. So we understand the challenges there. But those are the kind of things that go into those discussions. So, the long and short is the earlier the better. When we hit some of these clinical triggers that seem like we're nearing the end of life, maybe we do make that hospice referral. And I think that's a tough thing for somebody to evaluate someone who has lived with this disease for decades, and now we're nearing the end of it. So what are the thresholds there? It's that GOLD guidelines recommend the FEV1 less than 30% or significant disease progression rapidly for folks that maybe didn't have interaction with healthcare. It's that breathlessness at rest despite opioids and some of the kind of simple things, having the fan blow across their face, all those kind of dyspnea treatments that we can utilize. Severe hypoxemia despite maximum support at home, right heart failure. You mentioned the dependence on oral corticosteroids. Like if that's a constant state, we know the complications that come along with that. And then there's the things that go along with the disease that aren't necessarily the disease itself. If you're that breathless, it's really tough to get adequate nutrition, right? So low albumin, cachexia, the kind of temporal wasting, those can be signs that maybe we're transitioning towards the end of life here. And then depending on the patient, just a functional decline is enough to say, you know what, I don't want to be persisted like this. I don't want to live in a skilled nursing facility dependent on all my care. So tough things to talk about, especially with the increased demands, I think especially on APPs to be efficient healthcare providers and to have this limited time in clinic to go through these tough things. But the earlier the referral, the more people involved, and the more compassionate the care is only going to benefit our patients.
I have 2 questions. One, when you're talking about the ECMO and the process there, because I don't work at a university, which is where most of those types of ECMO can be provided, the ECMO at my hospitals are just related for heart surgeries.
Yeah.
So do y'all have struggle with that? Or do y'all, I guess my question is, do you have enough machines that if they need and the support team to manage the ECMO?
Yeah, no, it's a great question. It's a limited resource. There's not an infinite amount of ECMO, just the same way that there's not an infinite amount of ventilators, and we saw that during the pandemic, right? We have to have these contingency plans to say what happens when we run out. The way that things work right now is our cardiac surgery team has a committee of 3 folks at any given time that help make a decision whether or not they're going to initiate ECMO on an individual patient. From our side, it usually benefits to reach out to them earlier. When I was going through my specialty training after school, the one lesson I pulled out of the cardiac ICU was, if you're thinking about calling for ECMO, you're probably a day too late. So if the thought crosses your mind, you have those resources available, even if it's coming from an outside institution, the earlier the consult, the better, because there's going to be a lot of discussions that go into whether or not this patient is a candidate, especially the COPD patient. That's really not a great indication for these kind of interventions because of that overlap of acute exacerbation and end-stage disease.
And the other was more toward the palliative care. I know every state's a little different about who can make the medical decisions, which is one of the things our palliative care does help. Yeah. When you have a family that mom comes in or mama comes in and she's got 8 kids, who makes the decision? She doesn't have a spouse. And of course, unfortunately, we even have those who have, lived with someone for 20 years. But in the state of Mississippi, that is not acceptable. You're not, we don't have a marriage because of you living with them. And unfortunately, we do have some that have a girlfriend they've lived with for 20 years, but they still are married. And the wife has to make the decisions, and sometimes that causes a lot of problems. So trying to figure out who can make the decision, because if you got 8 kids, all 8 are not going to decide the same thing. So that's how we get palliative care, because they can help hold some of the meetings with those families so we can get a little bit more guidelines. Because we have meetings, so the advanced practice providers and our physicians talk to families, or we try to talk to families frequently, especially those who are deteriorating and we're not improving, and now we've got to start making some hard decisions about how can you come up with a plan. Hospice is not always the first choice, thankfully, for some of ours. I mean, when I talk to families, my goal is, okay, what would mama or daddy want if he could tell us what they wanted? Have they talked to you before about, do they want a trach and peg? Oh, no, they don't want that. I said, well, then we've got to think something else, because if we can't get them off the vent by a certain time frame, we've got to start thinking about that, because of the process that goes along with having I call it a big garden hose stuck down your throat. That ET tube does cause damage. Even a trach can, but that ET tube causes damage, and we have to start thinking of other options. So does y'all's palliative care essentially come in, make their own notes, bill for their services and stuff? Okay.
Yeah, absolutely. It's a full consult service within our hospital. They do help us a lot with those kind of things. We also have an ethics and a legal team as well for those particularly sticky situations to help navigate that, because it is tough. New York State's pretty good. There's a published pretty clear list. There's a few points that are maybe a little open for interpretation, but it's usually pretty straightforward in terms of, we do have common law marriage in New York. So living together with shared expenses for a certain time frame, that person would qualify as a surrogate decision maker. Now, where things get a little tricky is when someone does pass, the surrogate decision maker and the next of kin are not necessarily always the same people. So the person you ask about withdrawal of care is a different person than the one you ask about autopsy afterwards, which creates some interesting dynamics. So it's being familiar with those rules in your state so you can try to head any kind of conflict off at the pass. But our palliative care folks do a great job of helping us out with that. We do it all the time in the ICU. It's one of the things that I'm particularly passionate about, is having those conversations and helping folks do the impossible, which is to speak with somebody else's voice. And we ask our families to do that all the time, and it's challenging.
I think that just listening to the discussion about the struggles of inpatient management of end-of-life care makes it more important to understand that the thought of palliative care, end-of-life care, starts in the outpatient setting and should actually be on the mind at the diagnosis. Is this patient severe enough or exacerbating frequently, or is it appropriate to start discussing palliative care? Because I think, like you said, there's that confusion about what palliative care can do, and it helps to manage chronic illness, which is what COPD is. Yeah. And so I will always refer patients to palliative care, or at least have that discussion. Would you like an additional resource to have? And then I think definitely thinking in the more clinically in the outpatient setting about counseling patients on having those tough conversations with their family ahead of time, even if death's not imminent or anywhere near in the future, at least getting them thinking about this is a chronic illness. It could progress to the point where you might have to make these decisions. And so then to help further down the road, if and when that time comes where, hopefully it's a smooth transition and not a difficult transition for them or their family.
Yeah.
I think a lot of ours we'll see that it hasn't really, their diagnosis does play on it. But a lot of times it's because they've already been on a ventilator and they don't ever want that again, or they've already seen a loved one.
Yeah.
And unfortunately, just because their loved one was on a ventilator sometimes, because, we have talked some patients, we've tried to talk patients into having ventilators because we're saying, we just want to get you past the hump. We think we can get you off because you're not to that point. You're not on home oxygen. You're not on, neb treatments every 6 hours. We just want to get you past this hump, and we have some that will go along with it. And all right, I'll give you 1 week.
Yeah.
And then you have some that no matter what you tell them, so you just really have to use some aggressive, non-invasive and measures to try to improve them. So,
well, it's tough, right? Because no one wants to be intubated, but if the option is death, that's usually the deciding point. Well, this was a great talk. I appreciate y'all very much. I'm looking forward to trying to pare this down for our 30 minutes that we have tomorrow. Is there any other questions or any kind of closing remarks?
No, I just think, with COPD, it is still one of the top leading causes of death and chronic progressive disease. And so we need to make sure that we're thinking about all those things when we're managing inpatient, outpatient, end-of-life care.
exactly.
Well, thank you all very much. And
Thank you.
Thanks, APAPP.